Hello dear doctors, welcome back you again. This is the third part of the OSCE from the radiological diagnostic, and this is the last part for this time. But I'll assure you that this type of videos and knowledges I'll keep on sharing. Okay, so let's just start. This is question number 21 because I'm continuing from before. This is just a continuation. So look at this X-ray and what are the findings here. This is the X-ray of the skull. Okay, skull X-ray, which is showing punched out lesions. These are called punched out lesions. Okay, these are called osteolytic lesion. Osteolytic lesions. Osteolytic lesion means there is destruction of the bone. See this? Because this area looks relatively blacker, and there are nice margin. These are quite well demarcated and punched out lesions and osteolytic lesions in the skull. So if a patient presents like this and and they will give you some other clinical clue like Benz-Jones protein in the urine. Okay, and this is a case of multiple myeloma. Multiple myeloma is the most common primary bone tumor. Okay, and actually the source of origin of this malignant tumor is plasma cell. Okay, you all know what is plasma cell, right? Plasma cell is developed from the B cell or B lymphocyte. Okay, this is the cell which forms antibody. And in case of multiple myeloma, because it is a malignant tumor, there is abnormal type of antibody will be formed. Okay, so remember this picture is very commonly asked in many exams these days. Let's move on. Now another case. Okay, see here, this is a barium meal. Okay, barium meal. Now barium meal is showing typical finding here. Okay, the barium is collected in this area. Let's say this is area A, which is the fundus of the stomach, fundus, and this is the duodenal cap. Okay, area B is called duodenal cap. Okay, and this is the body of the stomach here. Okay, body of stomach. You can say this is the greater curvature, this side is a lesser curvature. Okay, and very clearly shown there is an arrow here. So if you think properly, this is a case of duodenal atresia. Okay, duodenal atresia. Why? What do you mean by duodenal atresia? Atresia means that area is blocked, it is not formed. So there is no passage from this area, it is blocked here. So the barium is collected here. Okay, when the patient has swallowed it, it is not going distal to it. Duodenal atresia. Now this duodenal atresia is having typical appearance in the plain X-ray. When you take the plain X-ray, we call it double bubble shadow. Double bubble shadow. It almost looks like a double bubble shadow, but actually this is a investigation of barium meal, so we don't exactly use this term, but still we can compare it. Okay, let's say this A is one shadow and the B is another one, so this is double bubble shadow. And one of the question which is very commonly asked here is in which case duodenal atresia commonly occur, and the answer is Down syndrome. Down syndrome. Okay, this is one of the conditions where duodenal atresia is very commonly seen, so don't forget that. Okay, now immediately there will be some more questions which will be asked to you. What are the other findings in Down syndrome? Okay, let's quickly talk about this in 1 to 2 minute time. Now Down syndrome, first is the karyotyping. The karyotyping is 47. Okay, sorry, this is trisomy 21. Okay, trisomy 21. I was thinking something else here. Trisomy 21 means there is one extra 21 chromosome. Okay, now another important point here is these babies are mentally retarded, they are intellectual, they are having intellectual disability. Intellectual disability. These days, we prefer this term over mental retardation. IQ level is less than 70, okay? Is less than 70. This is the definition of intellectual disability. Another important point is mongoloid face. Mongoloid face. Okay, this is very typical finding of Down syndrome. Another important finding here, okay, is epicanthal fold. Epicanthal fold, which is an extra fold of the skin towards the medial canthus of the eye, or you can say extra, lid of the eye. Okay, epicanthal fold on the medial side towards the medial epicanthus. Another important point here in Down syndrome is protruding tongue. Protruding tongue. This baby takes the tongue out most of the time. Actually, this occurs because of a small oral cavity. Small oral cavity, okay, rather than big tongue. Another important point is in this baby, in the hand, there is a simian crease. Single palmar crease is there. Okay, single palmar crease. Another, these babies are commonly having congenital heart disease, and one of the most common type of congenital heart disease is called endocardial cushion defect, ECD. This is a very important question in the exam, ECD. Now, another problem is duodenal atresia. That's what we are talking right now. And okay, Hirschsprung's disease. Hirschsprung's disease is another important condition which occur in a child with Down syndrome. When they become a bit older, they develop Alzheimer's disease. Okay, Alzheimer's disease. Alzheimer's disease is one of the most common cause of dementia all over the world, and they can also get acute lymphoblastic leukemia. So these are, dear students, a very common question from the Down syndrome. Okay, remember this is trisomy 21. Now let's move on to another case. Look at this X-ray very carefully and try to find out the important findings here. Now when I look at this X-ray very carefully, there is a gas under the diaphragm. See here, this. So diaphragm, you can clearly see the diaphragm here. Okay, diaphragm, and there is a gas under the diaphragm. So I can show you like this. This is the diaphragm here. Okay, on this side and on this side, the dome of the diaphragm. So there is a gas under the diaphragm. Gas under the diaphragm on both sides. Here also, but on the left side there is a fundal gas all the time, fundal gas, which is normally present. So even if there is a gas under the diaphragm, you will get confused, whether this is a pathological collection of the gas or the normal gas which is usually present in the fundus. That's why we usually look at the right side. Okay, but you can look at the left side as well. Okay, but just to avoid the confusion, we usually follow the right side. Now another term for this is pneumoperitoneum. Pneumoperitoneum. Pneumo is gas, peritoneum is a abdominal cavity. Okay, so this is the diagnosis, pneumoperitoneum. Then what are the causes? The common causes for this pneumoperitoneum or gas under the diaphragm are perforation of the peptic ulcer, perforation of peptic ulcer, both gastric as well as duodenal ulcer, one of the most common cause. The second is rupture of any viscera. Rupture of viscera. Viscera means internal organs like the GI tract. Okay, perforation of the typhoid ulcer, rupture of the appendix, any trauma to our GI tract which can cause leakage of the gas there, all of these can result in pneumoperitoneum. Okay, and very rarely the infection by gas forming organism can also result in the same thing. Okay, now whenever pneumoperitoneum occurs, we usually believe there is a rupture of the viscera, so there is a leakage of the food particle there or maybe stool there, so it can inadvertently result in peritonitis. So the treatment is we have to open the abdomen. We need to find out where is the problem, you remove all those leaked material from there. Okay, you wash out the peritoneal cavity very well, and then give the antibiotic at the same time. This is a very serious condition, so it is considered as a surgical emergency here. Okay, pneumoperitoneum. Now let's move on. Now there is one case from the cardiovascular system. This is one of the typical case. Okay, this is the spot diagnosis actually. This is called egg on side appearance. Egg on side appearance, or egg on string appearance. Egg on string appearance. Okay, so if this much information is given to you, now directly you can say this is a case of TGA, transposition of the great artery. Transposition of great vessels or great arteries. Okay, so what are the great arteries we mean here? They are the ascending aorta and pulmonary trunk. So normally pulmonary trunk arises from the right ventricle and ascending aorta arises from the left ventricle. But in this case, which is TGA, they switches their origin. That means pulmonary trunk originates from the left ventricle, whereas aorta originates from the right ventricle. And this is absolutely abnormal type of circulation. Okay, that's why it is called cyanotic congenital heart disease, and life is not possible until and unless there is some mixing of the blood. Okay, now see there. So what are the way of mixing of the blood? Okay, this mixing of the blood can occur because of the shunt, and this shunt can be ASD, can be PDA, or can be BSD. Okay, ASD and PDA can occur more commonly here along with this TGA. Now one more thing which can occur in this case. Okay, see here, this is a picture of TGA. You can clearly see here. This is right ventricle and here is the left ventricle. Now see this, from the right ventricle the aorta is originating. Look at the three branches of the arch of the aorta. Okay, so this is aorta, which you can easily identify, and from the left ventricle the pulmonary trunk is originating, and it is divided into two branches, and it is taking the blood to the lung. So it looks so abnormal. See this, the deoxygenated blood is going to the systemic circulation all the time, and the oxygenated blood is going to the lung all the time. Okay, very abnormal. So the baby cannot survive until and unless there is some mixing of the blood. So in this case there is ASD present. This ASD is mixing the blood. Okay, that's why the baby can still survive. So this is transposition of the great artery. Now one common problem here is, okay, there is increased pulmonary blood flow. As a result of this, it leads to pulmonary plethora. Pulmonary plethora. And this pulmonary plethora, okay, later on, all that blood whichever go to lung will come back to the heart, and this can result in congestive heart failure. Okay, this is one of the presentation in TGA, and there is a cyanosis. This is called central cyanosis because it is one of the important type of cyanotic congenital heart disease. Okay, and over a long period of time it can result in clubbing as well as polycythemia as well. Okay, clubbing as well as polycythemia. And dear students, one of the most important question which you will be getting in your future exam is, if there is PDA which is maintaining the mixing of the blood, you don't close this PDA here. Okay, rather you want to open it, you want to continue it. So that's why, to maintain the patency of PDA, we'll give prostaglandin. Okay, prostaglandin infusion is given. So this prostaglandin will keep this PDA open. Okay, so this is a very important question. Don't close this PDA, or don't allow this PDA to close. If PDA is closed, this baby may collapse and die. So PDA must be maintained. This is called ductal dependent lesion. Ductal dependent lesion or circulation. So these are some of the very important point here. Let's move on. Now, another case is from the abdomen. Look at this plain X-ray of the abdomen. Okay, and what are the findings here? It's a straightforward case. You can see stack of quines appearance. Stack of quines appearance. Now, whenever you see stack of quines appearance inside the intestine, okay, usually these are the small intestine, and especially jejunum. Okay, importantly jejunum, because in jejunum, whenever intestinal obstruction occur, okay, the valvulae conniventous are seen. Valvulae conniventous. These are typical, term. These are seen, and this valvulae conniventous looks like a stack of quine appearance. This is how we identify it. So, what is the diagnosis? This is small bowel obstruction. Small bowel obstruction, or you can say small intestinal obstruction. Now let's talk a little bit about small intestinal obstruction very quickly. What are the cardinal features of small bowel obstruction? Now, cardinal features means when these features are present, you can give a diagnosis. So these are called cardinal features. Okay, so these are the 4 cardinal features here. 4. Number 1 is vomiting. Number 2 is constipation. It can be absolute constipation, okay, or relative. Absolute means it is obstipation. Obstipation means even the gas is not passed. Okay, this is important knowledge. And number 3 is abdominal distension. Abdominal distension means gradual swelling of the abdomen. And number 4 is abdominal pain. Okay, this vomiting, dear students, a little bit, 1 more minute, okay, because it's important knowledge. Vomiting can be bilious, okay, usually, or it can be non-bilious. Non-bilious is a bit rare because we are talking about the small bowel obstruction, and if obstruction occurs distal to the second part of the duodenum, the vomiting is usually bilious. If obstruction occurs proximal to that, then there will be non-bilious vomiting. Okay, so constipation we already talked about. Abdominal distension, mainly because of fluid and the gas collection inside the bowel. And abdominal pain is usually the colicky type of abdominal pain. Colicky comes and goes. Okay, so these are some of the important points. Now quickly, what are the causes? Some of the causes of bowel obstruction. Okay, some of the important causes of the bowel obstruction are hernias. Okay, hernias. Adhesion means prior surgeries have been done there, so after the surgery there will be formation of some fibrosis inside the abdominal cavity. They can result in adhesions, which can cause bowel obstruction. Then intussusception means the proximal part of the bowel is telescoping into the distal part. Okay, intussusception, it can result in obstruction and ischemia. Then volvulus, twisting of the bowel over a right angle. Okay, volvulus. Some of the worms, okay, like ascariasis, a ball of ascaris may also lead to obstruction. Tumors, so etc. So many other causes, but these are the common one. Let us go to the other case, a same case here actually, but different type of X-rays. Okay, so this is the X-ray which was shown before. This X-ray is taken in a supine position. Understand? But this X-ray which is shown here is taken in the erect position. Means the patient is standing here. Erect abdominal X-ray. So what this X-ray is showing us? Okay, this is called step ladder pattern. This step ladder pattern is also very typical feature of small bowel obstruction. Why it is small bowel obstruction? Look at these loops. They are present towards the center of the abdomen. okay, center of the abdomen, and there are many, air fluid levels, many air fluid levels, air fluid levels. How we know this air fluid level? Look at the straight line there, whenever you can see straight line, these are all air fluid level, multiple. Okay, so this is small bowel obstruction again, and few of the causes, we already listed just now. Now a little bit of more knowledge. Actually there are two types of bowel obstruction. Okay, bowel obstruction is roughly classified under two headings. One is called dynamic, another is called adynamic. Now dynamic means there is peristaltic movement still present. There is active peristaltic movement still present. Okay, but in adynamic, this is also known as paralytic ileus. There is no peristaltic movement now. So all those causes which I've just mentioned are dynamic type obstruction, but let's give you the name for the adynamic obstruction or paralytic ileus. One is hypokalemia. Don't forget it, very important question. Another is mesenteric vascular occlusion. Mesenteric vascular occlusion or mesenteric artery ischemia. And third, okay, maybe some of the neurological problems. Yeah, okay, and one of the example you can give here is Hirschsprung's disease. Hirschsprung's disease as well. Okay, because that area, where there is no nerve cells present, that area cannot have peristaltic movement. Okay, so we can consider that. But remember one thing, proximal to that area, because that area acts like obstructed site, proximal to that area is actively having peristaltic movement, and there is a huge dilation of the bowel there. So this is a very quick revision for us. Okay, let's move on. Another case here, okay, is another abdominal x-ray which is showing Hirschstrations. Look at this. These are called Hirstra or Hirschstrations, and then bowel loops are present at the periphery of the abdomen, peripheral part of the abdomen, peripheral part. So if they give you a typical history, this patient presents with abdominal distension, vomiting, constipation, abdominal pain like that. This is a case of large bowel obstruction. Large bowel obstruction. Okay, or large intestinal obstruction. So some of the causes can be volvulus, okay, volvulus, okay, and all other causes which we have mentioned like tumors, okay, tumors, even hernias, okay. And one of the important tumor which can lead to this is called colon cancer. Colon cancer. There are two types of colon cancer usually, right and left. Left-sided colon cancer usually cause intestinal obstruction, and right-sided colon cancer usually cause hemorrhage or bleeding. Okay, very important point. That's why I've mentioned it here. Now, number 28. Okay, look here. This is again the plain X-ray of the abdomen, and you can see a hugely distended bowel here. Okay, distended bowel, and this probably the rectum, sigmoid colon, and even the transverse colon. So this distended bowel looks like a case of Hirschsprung's disease. Hirschsprung's disease. And you will get a classical clinical clue for Hirschsprung's disease, and that is they will provide that this is a newborn baby. Okay, newborn baby who has not passed meconium in time, or there is a delayed passage of the meconium, or not passed at all, when the baby was brought to us. So delayed passage of meconium. This is a typical history in Hirschsprung's disease. And when we examine, the abdomen is distended, it looks bigger, okay, and when you do some certain investigation like this, like a barium enema, or some other investigation, you can diagnose it. And what is Hirschsprung's disease? A little bit of knowledge. Let's utilize this time here. Okay, Hirschsprung's disease is also known as congenital aganglionic, aganglionic megacolon. So this is a very important term. So try to memorize it. Congenital aganglionic megacolon. Congenital means from the time of birth. Aganglionic means loss of ganglion cell. Megacolon means hugely dilated colon or large intestine. Okay. And what is the main problem here? What is the basic problem or defect? That is absence of the ganglion cells. Okay. These ganglion cells means they are Meissner plexus, Meissner's plexus, and myenteric plexus. Okay, myenteric plexus, also known as Auerbach's plexus, which are absent. Now, dear students, you all know what I'm talking about here. Where are these plexus present? They are present. Okay, the Meissner's plexus is present in the submucosa, and the myenteric plexus is present in between the muscle layer, between the circular and longitudinal muscles. Okay, and mainly it is absent in the rectum, a small segment in the rectum. So proximal part than the rectum is dilated. It is normal and it will be hugely dilated, and rectum is affected part, so of course it is contracted, and this part acts like a obstructed segment, and below than this, okay, distal segment will be collapsed. So this is a typical presentation of Hirschsprung's disease, and these children they mainly present with constipation, which is alternate with diarrhea, because constipated stool, if it is remaining there for a few days, then the coliform bacteria or the normal flora which are present there will liquefy this stool, and a lot of gas and liquid will be formed. So suddenly the baby will have diarrhea for a few days, and again it is followed up by constipation. It's a typical history of Hirschsprung's disease. And one more feature is this baby usually lose weight, they don't gain weight properly. Okay, very good. So let's move on. Now another case is from the cardiovascular system. Now very clearly it is shown there is a figure of 3 appearance in the chest X-ray. If this type of X-ray is shown, then this is a case of coarctation of the aorta. Coarctation of aorta. Okay, and you all know what is coarctation of the aorta. After the origin of the left subclavian artery, there is acute narrowing of the arch of the aorta. Okay, this is called coarctation of the aorta. So this is the diagnosis, and what changes occur at the left ventricle. The left ventricle will develop left ventricular hypertrophy, and this is a concentric type of left ventricular hypertrophy. Concentric type means the hypertrophy occurs towards the lumen or the chamber of the left ventricle, so that the left ventricle chamber will become smaller in size. Okay. Now, what are the other problems of coarctation of the aorta? Let's list them. The other problems will be, number 1, there is radiofemoral delay. Very important point. Number 2, okay, or you can you have to write B here because I write A there. Okay, so B, there will be lower limb blood pressure is lower than upper limb blood pressure. Normally our blood pressure in the lower limb is more than upper limb, okay, normally, but in this case, because of the narrowing of the arch of the aorta, there is decreased blood flow to the lower part of the body, so lower limb blood pressure is lesser than the upper limb blood pressure. Okay, number C, what else? There will be formation of the collaterals, okay, then they form, they give rise to murmur on the back of the chest, these are called continuous murmur, and they can also cause rib notching or notching of the rib. These questions have been asked multiple times before, okay, in the FMG exam or in any other licensing exam. These are the favorite questions. Okay, and the development of the lower limbs also less, means growth of the lower limb, they look thinner. Okay, that is also important point. So coarctation of the aorta. Now, one of the important condition which is associated with coarctation of the aorta is Turner syndrome. Turner syndrome, which occur in girls. Okay, so don't forget that. These are the questions which are very commonly asked. So this is the coarctation of the aorta, you can see here, and after the origin of the left subclavian artery, there is acute narrowing of the arch of the aorta. Okay, so this is called coarctation of the aorta. Now, dear students, dear doctors, we have come towards the end, and this is the last case. Okay, so look at it very carefully. Describe the findings here. This look like a boot-shaped heart. Straightforward, you can write like this: boot-shaped heart. Okay, it is also known as core and sabot. Okay, core and sabot. So this is another term which is used here for the boot-shaped heart. And if boot-shaped heart occurs, it is a case of Tetralogy of Fallot, TOF, Tetralogy of Fallot. Now, why it looks like a boot-shaped heart? There is a special reason here, okay? Because of the obstruction of the outflow tract of the right ventricle. Okay, this area looks quite narrow, and as a result of the right ventricular hypertrophy, there is uplifting of the apex. As a result of that, it almost looks like a boot-shaped heart. Now, a favorite question is, what are the components of tetralogy of the Fallot? Okay, so the components of the tetralogy of Fallot is, I have collected one more slide, so it is easy for me to discuss there. Number one is a stenotic pulmonary valve. It is number one. It is also known as right ventricular, okay, outflow tract obstruction. Outflow tract obstruction. This is the other term. Second is a thickened muscle. This is right ventricular hypertrophy. Third is ventricular septal defect or VSD. And fourth, you can see right here, exactly in this area. See this? This is called overriding of the aorta. Overriding of aorta. What is the meaning of this? The meaning is the opening of the aortic valve, okay, or the aortic valve lies immediately above the VSD, so that the oxygenated and deoxygenated blood both can enter into the ascending aorta. This is called overriding of the aorta. Okay, so this is called tetralogy of the Fallot. Now, sometimes they may ask you another question here. What is called pentalogy of the Fallot? The pentalogy means there is one more finding there, and that is ASD is added on this 4. Okay. Now, what is the problem of tetralogy of the Fallot? The problem of tetralogy of Fallot, very favorite questions, That's why just one more minute, and that is number one. There is decreased growth of the child. Decreased growth of the child. So we can call it failure to thrive. Failure to thrive. Okay, decreased growth of the child because of the chronic hypoxia. Number two, it can lead to cyanosis, and there is central cyanosis in the child, okay, or the baby. Number three, there will be clubbing. This clubbing is a feature of chronic hypoxia. Number four, there is polycythemia, and polycythemia is because of chronic hypoxia again. Because of the erythropoietin released by the kidney, it will act on the bone marrow, and there is excessive synthesis of the RBC. Now, this polycythemia can result in thrombosis, and it can also result in hyperviscosity of the blood. Hyperviscosity of the blood. Both of these can result in ischemia, okay, of different body parts. They can also cause stroke, remember that. Now, another important problem here, okay, in tetralogy of Fallot is, okay, brain abscess. Brain abscess can also occur here because of the shunt, because of the mixing of the blood. Those alveolar macrophages which are present in the lung, they cannot do their job effectively. So still, microorganisms may be there when the blood is flowing to the brain, that can result in brain abscess. One very important question which will be asked to you: what is the chances of congestive cardiac failure or heart failure in Tetralogy of Fallot? The chance is very less, and we have got a reason there, because the VSD which is present here, VSD is, there's almost equal pressure on the right ventricle and left ventricle as a result of right ventricular hypertrophy. So VSD is almost silent here. Okay, that's why congestive heart failure is not very common. But in certain condition, the heart failure can still occur, and those conditions are anemia, any infection like infective endocarditis or other infection in the body, okay, any other heart disease, excessive fluid overload, cardiac arrhythmia, okay, all these conditions can still cause heart failure even in case of Tetralogy of Fallot. Now one more question: which type of murmur is heard in Tetralogy of Fallot? And the answer is ejection systolic murmur at pulmonary area. Okay, usually the murmur of VSD is not heard because of the silent nature of the VSD. Now apart from this, this is mainly the OSCE type of question, so I don't want to go to the whole topic here. So dear students, dear doctors, let me stop here for today, and I promise you we'll continue this type of session again. Okay, thank you.